Good morning, everyone. Thank you for coming today. I think we're about to start the webinar as well. Do we have that up and running? We're all ready to go, and I have to thank all those people out there. So when we're ready, let me know. Okay. Good morning and welcome to today's briefing and panel discussion, Integrated Primary and Mental Health Care, Reconnecting the Brain and the Body, brought to you by the APA and its commissioned release of the Milliman Report. Before I start, I need to just tell a quick little joke so we get it out the way. If you're worrying about my accent or thinking where it's from, it is from California. And if you're from California, it is Northern California, because that's where I did my training. But all kidding aside, it is originally from South Africa, but I now consider it American, although when I go back to South Africa, they hear it as American, and you here apparently hear it as South African. So with that out the way, let's proceed. Today, as the national debate once again relooks at mental health care, heightened by the Fort Hood tragedy, this makes today's discussion even more important. Debates about violence and mental illness is not the debate we should be having. Rather, access to care, research, finding funding for prevention, early intervention, and treatment with recovery wraparound services is what we should be discussing. I hope this event will help the nation and our administration and congressional leaders begin the discussion based on facts and science. My name is Dr. Saul Levin. I'm the CEO and Medical Director of the American Psychiatric Association. I want to thank you all for making time to be with us here today to discuss integrated behavioral and primary care models. And thank you to everyone joining us using today's live webcast. I know there are quite a few, and it's growing in numbers, of our members and district branches watching, and we're glad each of you have made the time to join from afar for the important discussion. There is an unprecedented amount of attention being paid to our nation's healthcare system. In the midst of debate about how to lower costs and improve outcomes, mental health care has increasingly become the focus for discussion for reform. Most recently, we saw this in the release of the Final Rule for Mental Health Parity and Addiction Equity Act of 2008, commonly called MAPIA, creating a momentum to improve the quality and access to care. But this momentum is accompanied by an increased necessity and commitment to sustainable change in how we deliver and pay for care. It has also provided us an opportunity to reconsider our models of care and think about how and where we provide behavioral health care for the people with mental health and substance use disorders. Integrated care models are one of the solutions to help expand access to quality care, leverage limited healthcare resources, and provide patients comprehensive care. They show promise for improving the quality of care and reducing the barriers to health care for those who have long faced discriminatory hurdles in getting the services they need and deserve the essential components of this approach is collaboration. In integrated care, psychiatric physicians, primary care physicians, and other mental health clinicians work together with the patients and the families to truly provide patient-centered care. This approach of integrated care utilizes a systematic and cost-effective approach to providing patient care. As you hear today from a variety of experts, these models have been shown to address a range of areas, including mental health and substance use disorders, chronic conditions, and health behaviors, and last but not least, ineffective patterns of healthcare utilization. I'm pleased to have such a distinguished group of presenters here today to discuss these models. Dr. Jeffrey Lieberman, my president and our president of the American Psychiatric Association and chairman of the Department of Psychiatry at Columbia University, will speak to the growing body of evidence supporting these models. Dr. Michael Hogan, the former commissioner of the New York State Office of Mental Health, will deliver the keynote remarks. Dr. Paul Summergrad, my president elect of the American Psychiatric Association and chairman of the Department of Psychiatry at Tufts University School of Medicine, and psychiatrist-in-chief of Tufts Medical Center, will present new findings on the benefit of these models. Relative to this event, he has also chaired the APA ad hoc committee that developed the report, The Role of Psychiatry in Healthcare Reform, that we will discuss today. But we're also fortunate to have two expert panels, including healthcare economists, primary care doctors, behavioral healthcare professionals, and advocates. I know we're all looking forward to the presentation, so at this time, I'd like to turn over the floor to Dr. Jeffrey Lieberman, President of the APA. Dr. Lieberman.
Good morning, ladies and gentlemen. It's really a pleasure to be here on this day, which I hope will sort of signal the start of something which has a transformative effect on the way our country delivers health care to people. There's adages that everybody is familiar with, such as there's no health without mental health. And the other one that I've heard, which I'm fond of, is the secret sauce to healthcare reform is mental health. And the key ingredient to that sauce is collaborative care and integrated care. And so, hence the title of this forum today, which is Reconnecting the Brain with the Body. As I think everybody in this room is aware, the epidemiology of mental illness is very substantial. Conservatively speaking, a quarter of people within their lifetime will have a mental disorder. Many of these conditions co-occur along with non-psychiatric medical disorders and occur in the setting in which people are getting medical or surgical services. However, given the fragmentation, the separation of our services and our provider delivery systems, they're often separated, and therefore the comorbidities don't go untreated, whether it's psychiatric comorbidity in individuals receiving medical or surgical care, or whether it's the medical comorbidity in individuals with mental illness receiving mental health care. Psychiatric training instills in doctors who choose to pursue psychiatry a specific set of skills to try and integrate understanding of the brain and behavioral disturbances with other physical conditions. Treatment by psychiatrists as part of the overall health care process really contributes to better patient outcomes and to improve healthcare resource utilization and ultimately cost effectiveness. So it's natural that we should consider how we can find a more efficient and more cost-effective way of integrating psychiatric and mental health care into general health care. The truth is, though, our workforce is not necessarily configured and deployed in an optimal way. Many places, because of lack of adequate numbers of psychiatrists, mental health providers, or geographic maldistribution, there's no psychiatrist to cover large populations or large areas in the country. More than half of the counties in the U.S. don't have a single practicing psychiatrist. And at the same time, research shows that 40% of patients with mental health problems initially seek care, or the first line of contact is in the primary care system. Talking to my colleagues, Frank and David, in family practice and pediatrics, 40% may be an underestimate. So this is a natural area for collaboration between psychiatrists and physicians, and particularly primary care physicians, to ensure that behavioral health becomes an integral part of overall health and vice versa. Now, this is not just a kind of platitude that I'm mouthing. There's actually a substantial body of evidence which supports this. Of course, Health economists and policy experts like Richard Frank, Mike Hogan may have the final say on this, but I'm hoping that they'll agree with us on this, that the evidence is very compelling. The studies have shown that concurrently treating behavioral and physical conditions not only leads to better control of the illness itself, but also better patient satisfaction, quality of life, and reduction in healthcare costs. The Cochrane group, which does these massive statistical analyses and meta-reviews, has reviewed close to 80 randomized controlled trials of integrated care, including more than 24,000 patients worldwide, and have found that collaborative care was more effective, particularly in terms of patient subjective experience, satisfaction, quality of life, and in ultimately the cost of delivering care. As we'll hear from our panelists, similar results are being seen throughout the country, and I'd like to think that this model, if not the idea, is spreading like wildfire. Right now we treat medical and mental illnesses as if they're in separate domains and they can be compartmentalized, but we all know that that's not the case. So your presence here, I think, indicates the fact that you and the organizations you represent have a sincere and enthusiastic interest in this area and a commitment to seeing this idea and model of care be embraced and integrated into our healthcare system. And it's dependent, our success in being able to do this is really dependent on us working together. No single discipline, no single constituency can do it alone. But working together, we really can take something which is gestated conceptually, been vetted through demonstration projects, and accrued a confirmatory body of evidence, and roll this out and integrate it into our care system with what we hope will be tremendously beneficial effects. So to get started, it's my great pleasure to be able to introduce our keynote speaker today, somebody who I know not just by reputation as one of the foremost mental health care administrators and policy experts in the country, but also as somebody who used to be my boss, but I still defer to him very deferentially, even though he's not formally so. But Dr. Mike Hogan served as a number of capacities, including as the state mental health commissioner or director in Connecticut, Ohio, and then most recently in New York. And he also was the chair of President Bush's Presidential New Freedom Commission on Mental Health, the last presidential commission to really take on this issue. In leading New York's public mental health system, he led the largest and most generously funded per capita basis of any public mental health system in the country. So please welcome Dr. Michael Hogan.
Well, thanks, Dr. Lieberman. It is really good to be here on this issue, and my assignment is to try to underline why this issue is timely, why it's important, and why this approach to integration is right. I want to commend the leadership of the American Psychiatric Association for this event and all the work that's gone into it, and for this position. It's a little bit unusual, in a sense, for a specialty medical organization to be talking about care that's primarily in the mainstream, as opposed to care entirely in its specialty. And I want to underline that point, but it is so crucial. Let me start a little bit with the timeliness of this issue. We are in an era now where it might be like global warming, where the movement of people with or concern about psychiatric conditions into mainstream healthcare is overwhelming. Yet we still behave as if the quote-unquote mental health system was a separate and a solution to these problems. Interestingly, the American Psychiatric Association was founded in the middle of the 19th century as an association of physicians who led the asylums that were the primary approach that our country used at that time to treat these conditions. But we've come a long way since then. with the enactment of Medicare and Medicaid, and with all the changes, particularly in the last half century, these conditions are now much more significant in the mainstream. So one way to sum this up is to say that the specialty mental health system is neither the problem anymore, nor the solution to the problems of access to care that so many people are faced with. It remains very important. So steps like the Excellence in Mental Health Act that was included in the Doc Fix bill are very important because they're going to help stabilize and sustain that specialty mental health system. But that's not really where most of the challenges are anymore. The challenges are in primary care offices, in hospitals, but not necessarily in psychiatric units, in home care, but not necessarily in special mental health programs. And this change that has moved us into the mainstream really is of overwhelming force. One of our panel members, Richard Frank, wrote with Sherry Gleed the best summary of recent history of mental health care in the United States. And they looked at the changes over the last 50 years, concluding that, as the title of the monograph illustrates, the well-being of people with mental illness is better, but not well. And interestingly, the main force that they discovered that made things better was the access of people with mental illness to mainstream benefits. The fact that health insurance had expanded, the disability benefits had expanded, that there was new access to care. Those developments were more helpful in sum to people than improvements within the specialty mental health system. And I want to illustrate the significance of the problem of integration in a couple of different ways. The epidemiological evidence now suggests that the average time lag between first having some symptoms of a mental disorder and first getting professional care is 9 years. In the United States of America, in the 21st century, the lag is 9 years. And since the average age at which people experience a mental illness for the first time, if they're ever going to experience it in their life, is 14, this means that this long lag time of things deteriorating, of getting worse, of not getting care, takes place during adolescence, which is a really bad approach to things. So we have this very long lag time that exists. People, if they go see anyone, are much more likely to see some variety of a primary care physician. And as we hear from some of our colleagues and leaders in different primary care disciplines, primary care is already slammed with these problems. Except for flu season, pediatricians have more visits where the chief complaint is behavioral than any other category of visit. In family medicine, Frank DeGroy would know the precise numbers, but upwards of a third of all the patients coming into family practice physicians have got some kind of a behavioral complaint. But without the tools to deliver good care there, the problem is likely to be put off. And we know a lot about what happens when we don't have integrated care. That is, when we don't have a team that is working together. If you walk into a disintegrated or an unintegrated primary care office, unless your practitioner is very tuned into these issues, with depression, your chance of getting a diagnosis is about 50-50. And if you get a diagnosis, the chance that you're going to get minimally adequate care, that is enough of something the research has said will make a difference, is 50-50. You add all that up, it's about a 1 in 5 chance that you're going to get relief from what may be the single thing that brought you in that day. This can be fatal. Multiple studies now point out that half of the 38,000 people who die by suicide in the United States every year, the number is probably more than that, except our statistics lag so badly that we don't know yet. 38,000 was the number of people who died by suicide in 2010. Half of those individuals have seen a primary health physician within the 30 days prior to taking their life. But our de facto policy has been don't ask, don't tell. It is not a good approach to these problems, which can be crippling or fatal, but can also be very treatable. The lack of integration is also a problem over in that specialty mental health system, where we tend to treat this part of the body and ignore the neck down. And so integration there is also really important to help address the fact that people who are actually getting care in the mental health system are dying on average 25 years before their life expectancy, mostly from cardiac problems. So integration of care in the mental health system is also really important, but it's not our primary concern here today. Our primary concern is on the much larger problem of integration in primary care. The report that Dr. Summergrad will present makes it clear also that there's a huge economic consequence of the failure to integrate medical and behavioral care. About a third of the people who have got any kind of a chronic medical illness, COPD, asthma, diabetes, and so on, are also living with depression or some other common and treatable mental health problem. And I can remember my mother's experience with this when she was alive. She dealt with both diabetes and depression, and it was just crystal clear that when she was managing her depression, she would manage her diabetes. When she stopped taking, as she called them, her shrink pills, she would stop monitoring her blood sugar, and really bad things would happen. It was just such a simple and direct relationship. For the 1/3 of people who have a medical illness who also have a behavioral health problem, the report that will be released today indicates that the total costs of care are doubled. And the costs of care are not doubled because they're using a lot of mental health care. The costs of care are doubled because of excess use of medical problems, like I illustrated, or excess use of medical care of situations like I described with my mother. That's just an example with chronic illness. We also have this problem in hospitals, where a third of the people who are in a hospital bed in the United States today, not for a psychiatric problem, but for a medical problem, also have depression, anxiety, some other treatable mental health challenge that, if addressed, would help them cope with their healthcare problem. It's unlikely to be detected. It's unlikely to be treated. They will stay, on average, a day longer in the hospital because of the failure to address and treat the behavioral health problems. And if you looked at a hospital bill, an extra day in the hospital is not inconsequential. And then when they get out, their chances of readmission to the hospital or of going to the emergency department for care are also greatly increased. So we need integration in primary care, we need it in inpatient care, we need it in aftercare. The other reason why this issue is timely and important, as Dr. Lieberman said, is the jury's now in that integrated care is effective. Now, integrated care is not like deinstitutionalization. You know, it's not hoping. It's not shift and shaft. It is taking concrete steps to put teams together to do this work. And as Jeff said, the approach that's labeled collaborative care is probably the best documented and best proven approach. So you have a mental health specialist of some kind, a social worker, a psychologist, a psychiatric nurse, who is on the floor with the medical team, available so that if the physician is seeing one and has concerns about depression, they can say, I'd like to ask Mrs. Smith to come down and join us. I think she can be of help to you in talking about this. If you decide you want a prescription to deal with this problem, I can prescribe that, but she can talk to you about how to adjust your life, how the medication will affect you, arrange other services if you need. So there is a warm and immediate handoff to care, which is going to be effective, as opposed to a referral to somebody on the other side of town where there's a waiting list, where you're not certain you're going to go there, and where in more than half the cases, the referral is going to land with a thud and there's not going to be follow-up. So collaborative care means having somebody on the floor. It means measuring what we do and seeing if people are getting better. And it means having a psychiatrist available to talk, usually by phone, with the treating physician or with the other mental health specialists to bolster the work that they're doing. And as Dr. Lieberman said, 80 randomized controlled trials now, and those research studies prove not only the effectiveness of collaborative care, that is, your mental health gets better, your medical, physical health gets better, and the total cost of your care goes down. You know, can we find other examples where an intervention has so many positive outcomes? The reason for the importance of this report is that doing this is proven, but it's not easy. There are still obstacles to integrated care. In one of the pages of that 2003 report of the President's Commission, there's a recommendation that Medicare should pay for the cost of collaborative care, and it still hasn't completely happened. I will say that Medicare has taken a lot of steps forward, but for example, there is still not a payment approach to pay for the psychiatrist to do the telephonic consultation. Another example of an obstacle is that a lot of us have our insurance set up with our mental health insurance in one plan and our medical insurance in another plan. These plans each have their own sets of providers. The nurse or the social worker or the psychologist who's in the primary care practice may be credentialed and able to be reimbursed in a limited way on the medical side, but they need to do mental health procedures as well. So separate insurance plans get in the way of this. Competing medical records get in the way of this. So the work of integration, although the mandate is crystal clear, is hard, and that's why I'm so appreciative of APA's leading on this issue, and why I'm so hopeful that those of you in the room and those of you who are watching will go forth to call for this and to work on it, because as with so many other issues, a report is important, but it's not sufficient. It's going to take us all to roll up our sleeves. I want to, with those sort of level-setting comments, turn the podium over now to Dr. Paul Summergrad, who, as Saul said, is the president-elect and has been quietly leading on these issues within the APA for some time.
Thank you very much, Dr. Hogan. And I want to thank all of you for being here and all of you who are joining us by the webcast from across the country, state associations, district branches of the American Psychiatric Association, and others. We're pleased as the American Psychiatric Association to release these two reports today, and I want to give you the context and the background for the work that we did. So we are releasing today two reports. One is the role of psychiatry in healthcare reform, which was the work of an ad hoc work group of the American Psychiatric Association Board of Trustees. And the second is that committee, that work group, commissioned an external report by Milliman, the global actuarial and consulting firm, to really help us look and see what are the costs, not just of mental health services, but the costs of medical care services as well for individuals who have psychiatric and substance use illness compared with individuals who don't have those costs. So we can understand the many impacts that psychiatric and substance use care has. Now, there are lots and lots of reasons for all of us to move towards people who have mental health and substance use illness. There are brothers and our sisters, there are parents, our children, there are ourselves, and people are suffering and people's lives are tragically affected by untreated and uncared for mental health and substance use illness. One of the other, though, hidden effects, and especially as we think now around healthcare reform, is around the impact on the total cost of care and people's combined medical and psychiatric care. So that's what we focused in on in this work. And today we're also going to talk about the triple aim and the way this works within the framework of the triple aim. So healthcare reform's triple aim is to look at improving the patient care experience, it's improving the health of populations, and it's reducing the per capita cost of health care. And these are principles that have been enunciated for all of health care, especially as we're trying to develop patient and person-centered health care that's organized around the needs of individuals, not the needs of the health care system per se. As we began our work within the American Psychiatric Association work group on healthcare reform, we felt that we needed some external work. So we turned to Milliman, and we really wanted them to look with us at what is the economic impact of integration. And we're releasing today for the first time the results of this report, which you have, for those who are here in the room, on your thumb drive, and will also be released online by the American Psychiatric Association. This report looks at individuals who receive mental health and substance use services and medical care services either through commercial, Medicare, or Medicaid insurance. It includes utilization and cost data from millions of patients, then extrapolated to the entire U.S. population. And it compares data both from those with chronic medical conditions, with behavioral health conditions, and those who have chronic medical conditions alone without coexisting behavioral health conditions. So what did we find? About 14% of individuals who have insurance use mental health and substance use services, but their total costs in the total healthcare system, looking at all medical and psychiatric care costs, but especially affected by medical care costs, is over 30% of total healthcare spending in the United States. What that means is that general medical care costs for people who have behavioral health disorders were found to be 2 to 3 times higher than those without behavioral illness. When we quantify this further, the expenditures that Milliman found under insurance for mental health and substance use services directly were $92 billion a year. But the additional costs that were incurred by people who have behavioral comorbidities across all insurance types was $293 billion a year, over what it would be for those individuals who don't have mental health and substance use services. And this was not something where people were going and seeing their doctor all the time. It was really the place where the increased costs were most dramatic were in emergency room utilization and facility costs, people coming admitted to a hospital or coming to an outpatient center for emergency care of some type or another. And of that $293 billion, the vast majority is related to medical surgical costs, not psychiatric care costs. We also asked Milliman to say, if we look at the work that Dr. Hogan was describing and Dr. Lieberman was describing, the work that really describes what is collaborative care, what's integrated care, what does the research data show, and if we were to extrapolate that, not as a promise today, but as a goal to strive for, what kind of impact could we have financially on the healthcare system? And their estimate was that we could save between $26 and $48 billion annually in general health care costs, again, predominantly associated with general medical care costs. Now, this is something that's going to need more work and more research to see whether that's really true. We need a lot more work, as we'll talk about, in terms of the findings of this report. But to summarize this work, it's essentially to say that mental health is not just important because of the human suffering that's involved. That's the most critical reason why it's important. There's too much pain and too much suffering going on in too many communities in this country. But it's also important because it's simply too large to ignore. It's too large in our prisons, it's too large in our jails, but it's also too large in our healthcare system and in our total general medical care cost of care. And it's something that we need to acknowledge and we need to find a better way of dealing with. So as we looked at this in terms of our work group report, which you also have, which is really around the role of psychiatry and then more broadly the role of behavioral health in healthcare reform, we looked really at 6 key areas. Contemporary reform efforts, what are people doing? What are the models for integrated care? How do we finance care? What are quality and performance measurements? What are we doing about health integrated technology, information technology, EMRs? And what are we doing about our workforce? And that workforce is not just the mental health workforce. It's really the general medical workforce, because we know from every possible study that the vast majority of care that's provided on an ambulatory basis for individuals with mental health and substance use is provided by primary care physicians and in the general medical sector. That's always been true. It was true in 1978. It's true now as well. So what did we find? And there's much more detail, again, in the reports that you have available to you. First, in terms of contemporary reform efforts, we need to be monitoring new models of care and making sure that we're enforcing both parity and compliance with other existing regulations, and it's going to be critical to make sure that we have a monitoring capability to know what's happening with healthcare reform as it relates to mental health and substance use, and that all behavioral health providers must play an expanded role in integrated behavioral and medical care. And that's also obviously true for all of our colleagues in general medicine and primary care. Secondly, around integrated care, we need more research to build the evidence base and to explore the financial impact and to define roles of all providers in providing this care most effectively. And psychiatrists, along with primary care physicians and other clinicians, both mental health clinicians and other clinicians, have a key role to play in providing integrated care solutions. We don't have enough people that we can waste anybody in this effort. We need everybody who's not only in this room, but listening and working together on these issues across the medical and the behavioral spectrum to work on this. In terms of financing of care, we need to find ways of moving towards integrated payment issues, integrated payment for care, so that we're not creating separate buckets which says this occurs in one universe, this occurs in the other universe, and the two will never interact with one another. At the same time, we need to be very careful to protect fragile behavioral health budgets, which have already been under pressure from a whole range of directions, both from economic and insurance and state government cutbacks. And the payer and systems must include behavioral care in broader budgets, and those budgets need to understand the impact of not including behavioral care within them. On quality and performance measurements, there needs to be more aggressive development of performance measures. We need to identify priority areas with clear metrics for success in specific areas, and we need to look at it not just in the framework of mental health and substance use care, but the impact on the total cost of care and the total quality of care. In health information technology, despite the challenges, successful integrated care depends upon electronic capabilities, which will allow people to cross-talk across medical and behavioral health systems. That's going to require investment, and it has to be a priority for the field, for patients, for policymakers and the public. And at the same time, we have to think very carefully and courageously about how we deal with issues of both confidentiality, but the need to make sure that the right information is available for the right patients at the right time so they're getting the care and the services they need. In regard to our workforce, without workforce changes, there's going to be difficulty meeting the demand for specialty services, and we need to provide enhanced training across the entire healthcare team. This doesn't mean just for individuals who are mental health providers or psychiatric physicians. It means all physicians, nurses, caregivers who work with patients and their families. So we are proud to be able to present this work. You have much more detailed versions of this. But we think that there is a compelling case to be made that mental health and the problems associated with it are not just too important to ignore because of the human suffering that's associated with them, which we're all familiar with, but also because there's no way we're really going to deal with the total issues around healthcare costs, unless we reach out to everyone and reach out across the mental health and general medical domains and make sure that we're all working together to provide that care.